Hello everybody, I'm Caroline Flint, Chair of Humber NHS Foundation Trust. Welcome to our Council of Governors public meeting this afternoon. I have apologies from Councillor Jonathan Owen, Dan Meek, John Arthur, Emma Dallimore, Marilyn Foster, Steph Poole and Stuart McKinnon Evans. Are there any other apologies? No? Okay, thank you very much. Did I hear a cough then? Yes. Brian?
Yeah,
Brian.
just I don't know that Tim's joined us. Tim's having problems with his internet connection, so he apologises if he's not here.
No, I'm here.
I can see him.
Tim, right, okay.
I've managed to get in. Thank you, Brian.
Thanks, Brian. Thank you. Tim's with us. Great. Okay, let's move on then. Minutes of the meeting held on the 17th of April. Are there any corrections to those minutes? Or I should say, actually, before we get to those declarations of interest, has anybody got an interest that is in conflict with anything on the agenda today? If so, can you let us know, and if necessary, remove yourself from that item. And just a reminder, please let the board support unit of any changes to your declarations of interest. Anything on that issue? No, okay. Minutes of the meeting held on the 17th of April. Are there any corrections to those minutes? No. Dan, Staff Governor Dan's name begins with an L and not an H. So if we can get that corrected, but if I can't see any other hands up. Oh, there you are. Dan's got thumbs up. I remembered from the part 2. There you go. And are there any matters arising from the minutes that colleagues would like to raise? Tim?
Yeah, it's page 8, minute, and it's really minute 29-25, and it's to do with my usual hobby horse, which is to do with neurodiverse. The minute says that the matter's been discussed with the ICB. However, there was no funding available to support the increase in demand. And today in the report, I don't know whether you want to take it under the Chief Executive's report, but in the Chief Executive's report, we've got further reference to it. Do you want me to deal with it now or then?
Could we deal with it under the Chief Exec's report,
yeah,
if that's
fine.
all right, Tim? But thanks for flagging it to us. Thank you. Any other matters arising from the minutes? No. Is the Council of Governors happy to approve the minutes? Yes? Okay. Thank you very much indeed. So anything from the action log, work plan or matters arising there? Anything from those? Nope. Okay, great. So we'll move on to item number 5, which is our usual standing item of having a spotlight on a service. And today I'm glad we've got with us some colleagues to share with us some insights into our services around mental health forensic and CAMS inpatient services. Inpatient services, it says on the agenda, are focused on our inpatient wards, and they're going to take us through about what they are, who they're for, and any improvement changes that are being made. And I think we have Paul Johnson with us. Paul's become a regular at Council of Governors, and I think Victoria Wilson and Dr. Hannah Saeed, is that correct?
Yeah, that's right.
Brilliant. Okay. Good to see you all. So let me hand over to all of you.
Thank you very much. Afternoon, everybody. I'm going to start, if that's okay, and then I will hand over to my colleagues to go through their parts of the presentation. So thank you, Katie. Yeah, so as you said, my name is Paul Johnson. I'm the clinical director. Vicky, do you want to introduce yourself?
Hello, yep, I'm Vicky Wilson. I'm modern matron for the acute CAMS pathway. So that's our inpatient unit, Inspire, the Orion unit, and the CAMS crisis team, home intensive treatment team, and paediatric InReach.
And Hannah?
Hello, I'm Hannah. I'm a consultant forensic psychiatrist by trade. I'm the current medical lead for the Humber Centre. So I'm representing the forensic services.
Thank you. So what we're going to do is just take you through a few slides, which hopefully gives you some context of what our inpatient units are and where they sit, within services, and also around what the priorities are, what the functions are, and some of the things that are driving some of our practice at the moment. Next slide, please. Thank you. So I'm going to start with adult mental health, and from an inpatient unit, I've just tried to put some pictorial view here of where things fit. So if we start with our inpatient units from a mental health perspective, we have Avondale, which is an acute assessment unit that has 14 beds. And the idea of this unit is to be almost like that clinical decision unit. So if somebody needs to come into hospital, they would often come into Avondale first. Unless it's somebody who's well known to us, they will go straight to the appropriate treatment unit. But if they're not, they come to Avondale, where we'll be able to do that first initial assessment to have a look and see how we can support somebody in their recovery journey. That might mean that they are then discharged, or they will go through onto our other treatment units. That sits very much with that support around it. We've got our community mental health teams. We've got our crisis and home-based treatment team and our hospital liaison team, where often people can come in through to Avondale. But we've also got the crisis pad, which, although is not an inpatient unit, and our step down beds, which Mind provide for us, where we can step people down out of inpatient units if need be. They're not inpatient units, but they're really important in looking at our overall kind of services that we've got to try and reduce that need for an inpatient unit and to support people on their discharge. So if people go through Avondale and they move on to our treatment units, on our next slide, shows how our inpatient units. From an adult inpatient point of view, we've got Newbridges, which is an 18-bedded male treatment unit. We've got Westlands, which is our 18-bedded female treatment unit. And we've got Millview Court, which is our 15-bedded mixed sex unit. When we say that it's a mixed unit, what within that, there is a very specific male and female environments, and also places that where people can have their own space with their appropriate for their agenda. We've also got PQ, which is currently our 10-bedded mixed PQ, which is our psychiatric intensive care unit, and that is currently at 7 males and 3 females. And we've also got our STARS unit, which is our mental health rehabilitation unit, where we do have 5 beds currently. We are currently doing a lot of work around our PQ, and which involves STARS, and around looking at how we can move forward in ensuring that we've got the right number of beds for people who need a psychiatric intensive care unit approach. It's people who are often cannot be appropriately cared for in our inpatient units due to the level of risk and level of the intensity of their symptoms. And the idea of the PQ unit is to be able to support people and then move people back onto our treatment units. Next slide, please. We've also got our older people's inpatient units, which again, trying to give that idea of that we've got the inpatient units down at the bottom, but we've also got our older people's community mental health teams, which support people when they come to hopefully prevent people coming into an inpatient unit, but also to support people after discharge. We've also got the crisis team in there, and our acute day service, which is to support, again, prevent people being admitted to an inpatient unit, but also to support people coming out of inpatient units in their transition back into the community. So in our bed base, in our inpatient units, we've got Maester Court, which is a 5-bedded mental health unit for older people with functional mental health problems. When I say functional mental health problems, that is around things like depression, anxiety, psychosis. We also have Maester Lodge, which is our 14-bedded organic inpatient unit. When I say organic, that is for people, predominantly people with dementia, older people with dementia. And we've also got Millview Lodge, which, although it says on there is a 10-bedded female unit, Again, the Millview Lodge is very much used around that it can provide care for both males and females within their own environments, and that is often quite fluid depending on the demand for those beds. Our whole focus, which I'll talk about in a bit, is around trying to make sure that we've got appropriate local care without people having to go out of area, and having that flexibility in our bed bases allows us to do that better. Next slide, please. So when we're looking at the staffing of our inpatient units, the core staffing is pretty much across the board of our inpatient units. And what I wanted to try and give a flavour here is that we've got a number of different professionals and staff who work on our inpatient units as part of that multidisciplinary team. So we've got things like mental health nurses, which you would obviously expect. We've got associate practitioners, which are associate nurse practitioners, who support that qualified nursing role. We've got healthcare assistants, but we also have occupational therapists. We have our activity coordinators, our APOTs, which is our associate practitioners for occupational therapist, very much supporting in that rehabilitation, in that activities, in that meaningful activities, which is really so important when somebody is an inpatient. We obviously have our psychiatrists and our medics, our pharmacists, but we also have pharmacists on the ward, pharmacy technicians, to really support that medication and that pharmaceutical approaches, which is just part of what we do on an inpatient unit. And we've got social workers. Again, really important to recognise that when somebody's in hospital, there are multiple things that are involved which affect people's lives, and we cannot ignore and cannot underestimate those social factors that come to play here. And having our social workers linked to our wards is so important at looking at ensuring that we provide that very much holistic care, but also it's that holistic planning and future planning on discharge. We also have our psychologists, our psychology assistants, and again, a really important part of this is our housekeepers, which we are really important in our administration staff. We also have peer support workers, and this is a role that we are getting more and more peer support workers, and we will continue to do that within our inpatient units. And this is people with lived experience who support people and support the delivery of the care on the units. And we also have access as well to things like dietitians, physiotherapists, art therapists where we have them, and teachers and CAMHS, but I'm going to leave that one to Vicky because she can talk much more about that. Next slide, please. The purpose of our acute inpatient units, and I think this is about all of our inpatient units, no matter what division it is one of the main purposes is to provide that safe and therapeutic environment for people who are in an acute stage of illness, where risk to self and others cannot be managed safely in the community. To manage acute symptoms and stabilise acute presentations. I've just noticed that says acute presentations, sorry, and prepare people to transition back into their community to continue their recovery. So hospital is not somewhere where you would want to be for a long time, because that's not a natural environment for people. It is sometimes a must and a need and as part of somebody's treatment, but it's one small part of that treatment and that recovery journey. And what we want to do is use that time to manage and stabilise those acute presentations and support people back in their own environment. The other focus and the purpose of our inpatient unit is that least restrictive recovery focused care. In line with NHS England guidance, we advocate for a morality and legal based duty to maintain the least restrictive practice, balancing clinical safety with individual freedom. So again, sometimes we have to use restrictive interventions, and we have to restrict people's access and whether they come and where they go from their units. But that is in that frame, that legal framework, and always trying to be as least restrictive as possible. Next slide, please. The focus is around trauma-informed, autism-aware and anti-racist care. The Trust incorporates these three central pillars by tailoring care to people's trauma histories, to recognise people's neurodiversity and their cultural identity, and minimising re-traumatisation for people when they're in care, when they're in hospital. we kind of, again, adult inpatients philosophy is built on the foundation of safety, recovery, equity and empowerment. Encompasses trauma-informed care, co-production, actually service users, patients being involved in their care, directing their care, but also beyond that, it is beyond how we deliver our care is so important for us to get that inpatient care absolutely right. All aiming to ensure that patients receive a therapeutic, dignified, least restrictive support environment, which is kind of to help to restore their well-being, their independence, and back into their own environment. Next slide, please. So I'm going to hand you over now to Hannah, who's going to talk to you a little bit about our forensic services.
Paul, I'd rely on you to change the slide. So look for a social cue from me. I do nod a lot, but yeah.
Okay, Katie's the next slide administrator. She's very good at it.
Right, so the forensic services. So the picture you saw in the picture that you can see here, the one at the top is the front of the medium secure unit, and the one right below it is the outside of the low secure unit. As you will have gathered from the slide, we cater to 2 levels of security, medium and low. These are based on a range of physical, procedural and relational security measures. These are there, of course, not just for the safety of the patients, but also for the workforce and for the general public. Our medium secure unit called the Humber Centre, both the sites are on the Willoughby Hill site. So the Humber Centre is medium secure with 49 secure beds. And then low secure is a 20-bedded unit. The easiest way for me to explain this would be that we cater to 3 main pathways, all male. So the male mental illness pathway, as you can see, starts off with Derwent. It has 10 beds, which is the male acute mental illness. The journey would look like, unless they were going back to prison, the journey would look like then moving on to the male treatment mental illness ward, which is called OOS. It is 14-bedded. And then from there onwards, low secure is also mental illness. So they would go to Pineview, which is a 16-bedded male mental illness pathway, and or Southwest Lodge, which is a 4-bedded, again, mainly mental illness for discharge, patients who are on the discharge pathway. Other than the male mental illness pathway, we've got specialist PD pathway. That is on Swale. If we can go back to the previous slide. Sorry, Paul. Yeah. So just talking about Swale. So Swale is 15-bedded, male personality disorder, and then we've got Ullswater, which has 10 beds, and they are male learning disability. Thank you, Paul.
Thanks.
So this slide then shows you the continuity of care and how that flows from us and to us. So we get patients from the community, from prisons, from courts, and then those who step down from high secure, for example, to medium secure to low secure, which is at Pineview Southwest Lodge, or straight to the community. We've got a specialist community forensic team, and then from there, patients are often moved on either to general psychiatry, or patients are taken from general psychiatry onto the forensic caseload.
Please.
So the Humber Centre MDT, we're much warmer than you think. Please visit us to know. I work with a very specialized team who look after each other, is my experience. But we've got, as you would, we've got registered nurses, we've got healthcare assistants, concerned psychiatrists and resident doctors. We have grown as a consult team to up to 7 psychiatrists now, and we've got resident doctors who range from higher training to lower training, and then to even foundation doctors who just complete their medical degree. So a range of resident doctors there, occupational therapists and assistants, Then we've got an art therapist and we've got vocational practitioners, all kind of work under the occupational therapy umbrella, social workers and psychologists. A bit that we're very proud of is the user involvement. We've got user involvement lead, and I've got their newsletter right in front of me. Some quite exciting events happened recently. Give you a couple of examples. So Armed Forces fundraising event, the big experience when all the patients went with staff to Sandal Rugby Club. Some cracking photos from there. But we're very proud of the user involvement, where it's not just an opportunity for kind of peer support work, but also for the patients to volunteer in events like these. Security and admin. Again, we've got security leads, admin manager, and they manage a range of reception, security, and secretarial staff and administrators. Primary care team, as a doctor, wouldn't survive without them. But yeah, it's a big team of nursing, a GP, physio, dietetics, gym instructors, and the lovely pharmacy team. And I'll then hand over to Vicky for the CAMHS bit.
Hello, thank you very much. So yes, this is our Inspire Inpatient Service Building. If we can go on to the next slide, please. So this is a depiction of how we work within the acute CAMHS service, but we also have our planned core CAMHS colleagues on here as well. So the idea is that part of the CAMHS journey isn't linear. It's not a linear process. All parts work together, and it's based on a young person's need and not necessarily based on that risk or severity. So all of our teams work together, and young people can be in and out of different areas or over several areas to support their needs. And it does absolutely look like the Magic Roundabout in Swindon, if any of you have had the joy of driving on there. But it was something that we could use to really try and show how we all work together. Next slide, please. So on Orion, which is the inpatient unit we have here at Walk Street, we're a 9-bedded CAMHS GAU, so general adolescent unit, and we support our young people between the ages of 13 and 17, right up until the day before their 18th birthday, with severe and acute mental health needs. So we have young people who have eating disorders, and we have those young people on the ward who cannot be managed in the community. We have really close links with our EDIT team, which is the Eating Disorders Intensive Treatment team, which really do help prevent admission and also really support the ward with with getting these young people home and working with the family to support their young people. So we have 6 female and 3 male beds on the ward, which is separated with the living space. So we have a male corridor, then our environment, our mixed space environment, and then the female ward on the other side. And we have a maximum of 3 young people with eating disorders at any one time. And this is just about the amount of input that these young people need. We do have nasogastric feeding available on the ward if we need to. We work really closely with Mill Lodge, which is part of our provider collaborative, and they have 10 beds there. So we work together to support the young people in our 6 places. We have a real focus on trauma-informed ambit and sensory. So our occupational therapist is brilliant at doing these sensory screenings and sensory assessments to make sure that we really are truly meeting the needs of our young people who are on the ward, just so we can make it as comfortable as possible for them. Our aim is for short admissions with support from community CAMHS. So going back to the roundabout or the way that we all work together, is the idea is that our community CAMHS colleagues will continue to be involved and provide therapy if they're having that, so it's seamless, so the young people still have that relationship with our community CAMHS colleagues. And then we just wanted to do a bit on the average length of stay. So in the last quarter, that was around 48 days for our young people who'd been admitted to our unit. Next slide, please.
You got the next slide up there.
Okay, thank you. So this is again a little bit focusing on our MDT. So again, we have registered nurses, healthcare assistants, we have associate nurse practitioners who have that extra level of training, and then they can go on to become registered nurses with further training. So we try to focus on growing our own. We have our occupational therapy and the therapy assistants, psychologists, and the psychology assistants are medics. We have 2 wonderful teachers who work with us here on Orion. They provide school every day for our young people, and we've had some really fantastic outcomes, such as a young lady that we'd had on the ward who hadn't been to school for 2 years, to leaving the unit with a host of GCSEs. So they work really well with our staff on the ward and really provide some teaching for those young people where they are at. And the dietitian's not solely focusing just on our young people with eating disorders, but they always look at our young people without a diagnosis of eating disorders and help with healthy living things, how to feed yourself and feeding yourself well. We've got a social worker, pharmacy techs, and of course our wonderful housekeepers. Next slide, please. And we've had a recent CQC inspection, and we've pulled out a few of the comments that were made and that we had from our CQC inspection, which we got good. We were rated good. And we were really pleased with how much the young people and the families fed back on how much we'd helped and support them. And yeah, it really meant a lot. So I believe that's my little bit back over to you, Paul.
Thank you, Vicky. Next slide, please. So what I wanted to just finish off on is some of the clinical areas of focus across all of our inpatients. And there's too many things to mention that's going on. So we're trying to kind of theme these up into 3 main areas. So next slide, please. So the first bit I've already mentioned is about our restrictive interventions and our aim to reduce restrictive interventions where possible. And this is in line with the Innovating for Quality and Patient Safety, ensuring prevention, wellbeing and recovery, and that our agenda continue to focus to reducing restrictive interventions, which is a priority in all of our inpatient units. We're continuing to make great strides in reducing restrictions where possible, but what we know is that what we need to ensure is that where we do have to use restrictions, it's making sure that they are used in the most appropriate way and when necessary and proportionate to ensuring patient safety and staff safety. So we have a regular RRI, as we call it, Reducing Restrictive Interventions Group, which is a regular meeting across all of our inpatient units. We have service users with experience as part of the RRI group. We have our own quality improvement plan where we concentrate on all areas of reducing restrictions. The next area, the second area, is around the culture of the care. And this is around how we provide that care and what our culture is like with our inpatient units, which is so important. We're part of a national programme at the moment, which is the Culture of Care programme, which is a national initiative that all mental health trusts have been signed up to. We have fully engaged in this programme, and we're finding that this is a really useful way of working with our colleagues, with our service users and with our colleagues from other areas to look at our practice. So it's not only just about improving our practice, but it's about learning from others. And again, it's around that enhancing that prevention, well-being and recovery. Really important when you look at our trust values and our aims and objectives is to make sure that we provide that most appropriate care, and focusing on the 3 key areas around that culture is around trauma-informed practice, autism awareness, and that anti-racist practice, ensuring that we are practicing with cultural sensitivity. We've got different units who are involved with this programme, and all of our units have their own individual improvement plans, and we're doing a lot of QI work, because that's that quality improvement work in where we've got staff, we've got service users working together, identifying themselves areas where they want to improve or they wanted to make some improvement, and doing that plan, study, act cycle in looking at how we can improve the way we're doing things. And we've also got other programs of staff development around our unit managers, which fits in with that cultural competencies, and also around some of our units are part of the Culture Care programme, which is looking at staff culture and staff development. Next slide, please. And the third area, which is kind of this is around our inpatient units as well, because it's so important, but it's so interconnecting with our community offer and our community teams, and how we can work as from resources we have in the trust, but also as a system to provide that wraparound care and support for people in the community. We want to ensure that people, when they need to come into an inpatient unit, that they come to an inpatient unit that is close to where they live. We want to reduce that need for going out into out-of-area placements. So that's places outside of our geographical boundary. And that is a constant piece of work and development that we're doing across our services. So next slide, please. So what I wanted to finish off with is that that is very much of a whistle-stop tour of our inpatient units around adult, older people, our children and young peoples, and our forensic services. What I will be doing is that I have been invited back to do a further presentation in a future meeting, and we will be then covering our other inpatient units, which is our learning disabilities services and our community services. So I'll be able to talk a little bit more about that then. I've got there's a link here. There's a web address here which takes you through to some to the website, where we've got lots of I suppose guides, and it's about a guide and taking you through some of our inpatient facilities. Not all our inpatient facilities are on there. It's very much around kind of our learning disabilities, and our children's services are on there. But this is being built on, and is something that some of our service users and staff are working as part of that. Culture Care programme, is making sure that we've got information for people that guide people through our inpatient units, so we can use that for people, so that before they come onto our inpatient units, to help them to get an understanding of what it's going to look like, what it's going to feel like. But there's an idea. If you go to the website, it can give you some ideas of our facilities. I'm going to leave it there, but if there is any questions for either of us, please don't hesitate to ask.
Thanks very much, Paul, Hannah, Vicky. As Paul said, this is almost part one. We're going to cover our inpatient units for people with learning disabilities and our community patients, so it's around physical rehabilitation at Malton and Whitby in the October Council Governors meeting. Any questions or comments? If you want to stick your hand up. Anthony. And then Jackie.
Thank you very much for that. It was very insightful. I've been lucky enough to visit the Inspire facility, which is very impressive. And I noted that you'd mentioned about the peer support workers. Do you have peer support workers that visit all of? Do they visit them, or are they in-house?
Okay, so from a forensic services point of view, Hannah, from a forensic services point of view, we do have some peer support workers. Please tell me if I've got that wrong. From an adult inpatient units, we have peer support worker roles on the units. We are trying to, we've had some roles, then we've lost some roles, and then we've got some roles back. It is a moving feed, but what we're trying to do in our planning going forward is to have peer support workers on all of our units, on every one. We have community peer support workers which do go on to our inpatient units with individual patients, but we need to, our aim is to try and get people across the board. From a CAMHS point of view, Vicky, from a peer support role on the inpatient unit.
No, we're on the same journey, Paul. We've had some funding, we haven't, just through the provider collaborative. So we are looking at how we get that started. We're really lucky that we have our Humber Youth Action Group who provide us a lot of information and feedback, and we have been and spoken to them. So we speak to a lot of our young people on the ward, and they help guide us as well with our current young people and people who've also been in the service and then left also are in our Humber Action Group. So they keep us on the straight and narrow, and they really help give us some excellent feedback.
And what's happening recently is that what we have recognised, and this has been part of our journey, is that we are looking, and we've got more of a robust support mechanism in place for our peer support workers and a clear strategy of how we support our peer support workers. But also it's really important to remember as well is that we want peer support workers, but we also want to recognise lived experience in all of our staff group. And that also gives some opportunity, some career progression opportunity for people coming into peer support roles. So we've had people who started in our peer support worker roles now, who are now qualified social workers, who are now qualified dialectical behavioural therapists. We've got people at all levels and different professions within our services that have got lived experience. But it's also recognising that peer support workers is a really important role.
Thank you, all of you. Jackie.
Thank you, Paul. Really nice to have that refresher. I'm Jackie. I'm the appointed governor for the University of Hull. We've met before. Yeah. I'm just interested in workforce because at the most recent NHSE meeting last week with what's called the health deans, so it's with the universities that supply health professional staff across Yorkshire and Humber, they were reporting a reduction of certain staff. So they were telling us that there's going to be between 0.4% and 1.3% less adult nurses needed, and mental health nurses and school nurses, which seems really counterintuitive when we think about what we need in our services. They're talking about a small increase for learning disability nurses, midwives and children's nursing, and a larger increase for community nursing. And I found that quite interesting, as I would consider school nurses to be community nurses. I just wondered what your feeling was about that, because it looks to me from what you presented that we're in quite a stable, this inpatient provision that you have has been quite stable for a while, hasn't it? But it feels like what's going to happen now with the new 10-year plan and the shift, do you think there's going to be any further threat to the amount of provision? Because I think these reductions are in NHS provider services and largely in hospital services that they're talking about. I don't know if that made sense. It was a long-winded question.
Kind of, Jackie, and I'll try and answer it. I think it's fair to say that workforce is always a challenge, but it also gives us opportunities. And I think that's the bit where, from our inpatient units, we have looked at different roles. And it's not always about that there's a scarceness of resource of different professions, because we always, and Jackie, we've been on this journey for many years around how many nurses you need, and then we go with too less, and then we have too many, and then we have too less.
Yeah, I mean, NHSE are talking about oversupply, which is really, I've challenged that. Don't start talking to us about oversupply.
Yeah. I think what we try and do is make sure that we've got the most appropriate qualified practitioner to do what's needed for our inpatient services. And we will always need nurses. We will always need mental health nurses. But what we've also tried to do, and as I think as Vicky said, is we've also known that we need to grow our own as well. So that's why as a trust, as an organisation, and our inpatient units are very good at supporting people going through that bit around going and doing the associate practitioner. Then as obviously you can then go on to top that up to being a qualified nurse. So we've got those pipelines kind of in place.
Okay.
The other bit is just, sorry, shall I stop now?
Sorry, don't want to stop you, Paul. I'm just a bit conscious of time, and there might be other questions. Is that all right, Jackie? Have you got enough
Yeah,
time?
thank you.
Perfect,
Yeah.
lovely.
Can I just come in? Because
Yeah,
I think Sarah's
Michelle.
coming in as well, Caroline. I think we're probably going to say the same thing, really. But I think it's a really difficult, I think you're right, Jackie, and it's a really difficult situation, and one that we are, I'm sure Sarah is as well, challenging. Because I think there's a perception at the moment, following the long-term plan and the workforce plans from a national point of view, that we don't need as many nurses across the board because of the workforce planning statistics and the fact that they're trying to obviously look at the operating model and the various shifts. So I think it's a bit of a, I think we are pushing back. That's all I'll say at this moment in time. But I think Sarah is as well. So just wanted you to know that it's not necessarily come from the providers themselves. It's a bit of a national steer that we're pushing back on at the moment.
Yeah, that's good to hear. Thank you.
Thanks, Jackie. I hope that reassures you. Sarah, is that okay? Did you want to add anything?
If I can just briefly add to that, Caroline, just to give,
Sure.
I think nationally as well, Jackie, there's, I'm sorry we've not met Jackie. I'm the new Director of Nursing, Allied Health and Social Care Professions. So
we need
pleased to
meet
meet you and other colleagues around the virtual room. Politically, this is because we've got some patches who have got newly qualified nurses who are struggling to get posts and to get jobs. And ultimately, this is what's appearing to be quite a sensitive issue in other parts of the country. That isn't the case where we are concerned. From a trust perspective, we are ensuring that we've got posts for our newly qualified nurses, and that's something that's really important to us, the point where we're putting in sort of additional support, working with you in the university, even if it means sort of doing a second interview to get them to where they need to be. So really invested in making sure that we have jobs for our newly qualified. As Michelle's alluded to, we need the delivery plan of the 10-year plan, which will include workforce modelling. So I think there's more yet to come on this, but that isn't something that I'm observing, particularly for us as a provider. So just to add that added reassurance, thank you.
Thank you. I put something in the chat because you're right. We're all right in this area, but we're keeping an eye on everywhere else.
Yeah, and I'm sure Jackie and Sarah, offline, you might want to obviously catch up and meet up, because I know Jackie is what you'd like to say about training, wouldn't you, and the contribution of the university, and share that. Good. Okay. Are there any other governors who've got a comment or a question before we give our thanks to the presenters? Anybody? Okay. There's lots in the chat that you'll have seen. I've put in the chat as well, just to flag that the September Governor briefing, we're actually doing a session on peer support workers, and it's being led by our friend Tom Nicklin, who you may remember, some of you, was a governor and has worked within the organisation in that role. And he got in touch and said he'd like to, he always is good at promoting that work, and he's right to do so. So he's with us in September. And I hope this refresh of what we do in these particular areas, we've got more to come in October in community and learning disabilities, has been helpful. The slides will be shared, of course, and please go to the website when you have a chance and dip into it. It's really, really good. And I think one of the things that I was thought was struck by when I went to the event recently, which is this sort of culture of care environment, is just some of the feedback from patients and service users about having some materials that show people what it's like inside the units, what the physical space is like. Of course, Dan, you work in estates. That's a really important part of this as well. It allays people's anxieties about what they might be going into, what the residential rooms will be like, what the bathroom facilities like, all of that sort of thing. Even the outside of the building and where to go and where to park. I think for both patients and their families and carers, it's just those sort of, TLC really in a way, but common sense as well makes a massive difference. And Emma, it's a shame Emma's not here today, because Priyanka and I met up with Emma and some of her colleagues from Humber East Yorkshire Mind. And you mentioned, I think, the crisis pad, Paul, for adults. We work with Mind on that. We also, there's the safe space for children as well. And I understand there's some exciting developments about a relocation on the Inspire site, not in the inpatient facilities, but in some of the other space, which sounds really exciting. And again, is a really good collaborative approach to working with the voluntary sector partners within our area as well, which is good. So thank you, Vicky. Thank you, Paul. We'll see you again, Paul. You think you've got away, but we're going to have you back. And thank you, Hannah, today. And again, just to flag, for those of you who didn't make the governor briefing the other week, we had a really great session on our forensic services, not just the Humber Centre, but what we're actually providing in prisons in our catchment area where we have contracts as well, which I think governors found who were able to attend helpful, and the slides will be going out on that as well. Thank you so much, everyone. Can we show our appreciation to our colleagues?
Thanks, everybody.
Thank you.
Perfect.
Thank you very much. See you all soon.
Lovely. Thank you. Okay. Brilliant. Yeah. Okay, we'll move on to the next item, which is my chair's report. I'm happy to take any questions on anything. Can I just flag and just to put on the record, welcome to Sian Johnson and Simon Mills, our new clinical and non-clinical staff governors. Very welcome. Dan Meek is taking over from Dominic Pershon as the partner governor of Humberside Fire and Rescue. So can I just put that on the record? Welcome to all of those. And just also to say thank you to Dominic and, of course, our friend Will Taylor, who was a staff clinical governor. Many of you have worked with Will over the last few years. And to put on record our thanks to both Will and Dominic for their service. Happy to take any other questions or comments on anything in the report. I hope it's clear and provides helpful information. Any questions? No? Okay, thank you very much. We'll move on to the Chief Exec's report. Michelle.
Yep, sorry, thanks, Carol. I'm just going to get off mute. I'm not going to go through it in detail because of time, because I also just want to pick up some headlines from the long-term plan, but we will be doing a development session, obviously, with the board on that, if that's okay. So just a couple of key points. Obviously, Lynn will update you on the operational situation where we are, but lots of detail actually within the plan. Just to say that we are currently planning for winter, which is what we normally do when it's hottest day outside. We are also planning for our winter flu campaign and our general winter plan together with the system. I'll draw people's attention to the ED streaming report. We are getting a lot of national attention on that, which is very positive, and I thank everybody that's been involved with that. We've had extensive involvement from service users themselves, and that continues to gain good feedback from the patients who are using it and good outcomes in relationship to reducing the waits in emergency department. Safeguarding, Sarah is with us, but there's a good piece on safeguarding, and if you remember, this is one of the areas that the ICB is looking to devolve down to providers. The national training plan is gaining momentum. This is where people will be passported in and out of organisations with the said mandatory and statutory training, which is something we've been pushing for a long time. It will be a lot more effective to do that. Lots on our equality and diversity and staff networks, but I will also draw your attention to the medical education piece. We've had 2 assessments in relationship to patient medical education, because if you know, we do quite a lot of training for resident doctors alongside nurses, etc. But this was particularly for our medical workforce, and we've got really clean reports for both the national team and whole medical school. In fact, we got some really good feedback from the national team, which was good. Digital, we need to do more from a digital perspective in the organisation. We have got a lot of digital solutions within the organisation, some of which we use, some of which we don't. So we're doing a big piece of work at the moment, looking at our efficiencies, linking them not just to our transformation, but how are we using the digital that we've got and where are the gaps. I hope you like the new format of the communication section, and obviously we've got health stars. So I'll pause there. I'll ask Lynn if there's any headlines from the operational report, and then if I could just have maybe 5-6 minutes just to whiz through the long-term plan, Caroline, before the session. I think that would be helpful.
Okay, and we'll come back to Tim's question. Do you remember he raised in the minutes about some around some of the waiting times?
Yeah.
Do you want to ask that again, Tim? And then maybe Lynn might pick that up as well.
Yeah, well, I was thinking it would be Lynn, in fact, who would need to pick it up rather than Michelle, frankly.
Yeah.
Thank you.
Is that
Michelle.
better picked up in item 16, the performance report?
Happy with that, Tim?
No, I'd rather deal with it on this. It's page, and it really addresses, as I say, to Lynn, I think. In the minutes, in your part of the Chief Executive's report, we've got the same sort of thing as said before in April. This is to do with neurodiversity waiting list. Dialogue is progressing with the ICB to agree a way forward on waiting times and for 2025, 26 and beyond. Well, I've heard it before, and in the last minutes, when we were dealing with the annual accounts, what is reported is that, and the chair actually said this, the chair responded to me, that the matter had been discussed with the ICB. However, there was no funding available to support the increase in demand. And the chair added that the board was discussing and looking at trajectories, etc. Well, when I look at Lynn's part of this of the Chief Executive's report, dialogue is progressing with the ICB to agree a way forward. I find there's a total disconnect between the minutes and what is said here. What, please, is the actual position at the moment about this so-called dialogue, or not the so-called, the dialogue? What is actually happening this time? And I think it was the same question I asked actually in April.
Thanks, Tim. Lynn.
Yeah, so to pick that up, we are continuing our dialogue, as I hope you would expect that we would, with the ICB, given the significance, particularly around support to children and young people who are on our waiting lists for diagnosis for ADHD and ASD. The focus latterly has been on, irrespective of there being no funding available, the ICB are spending more money, particularly with independent providers, because of the lack of capacity. We've raised that here before. We have more recently submitted another revised sort of business case, which would see that funding, if there was agreement to that, redirected to provide additional provision supported by the trust on this occasion, because we know our case demonstrates we can provide that service more effectively, more cost effectively, and in terms of better quality as well. So that's been submitted. Michelle obviously supported that as well. But unfortunately, Tim, we still have not got a response that gives us that clarity as to whether we can take that forward or not. But I guess we're not giving up on those conversations for this particular group of our population. They are really important. So there has been some further progress made. We have submitted a further case based on our updated, obviously, position around that demand information.
Thank you, Lynn. And I know if you do get the funding, you'll be telling everybody, and we'd be delighted. But if you could let me if you could update me as well, I'd be grateful.
I will.
Whilst I'm there was another on page 7, and it's something I'm delighted to see, but it links in with page 31, and that's about the PICU and the male and female, and the fact that you were in the report here on page 7, it says matters are being progressed about this, and I'm just pleased to see that we've actually, from page 31, that we've been approved for a grant for capital of £1.8 million to develop a female PICU. Great. Can you, I don't know whether it's you or Pete who should be giving an answer to this particular question, but when is it likely to actual physical building and use of the estate, is it likely to be in the year, not this financial year, but the following financial year, or is the money actually capital to be able to be spent this year, or what?
He
Lynn?
might want to pick that up.
Yeah, thanks, Caroline. So the capital is for this year, this financial year, Tim.
Right.
We're currently at an advanced design stage, at which point we then have to submit our business case to be able to draw down the funding from NHS England. So whilst the funding's approved in principle, we have to have our final business case signed off, and at the same time work with commissioners on the revenue support, because this will be stopping out of area spend and saving commissioners funding. But based on the current spend profile, we expect to be on site at the beginning of Q4, and we hope to have the works finished by the end of this financial year.
Oh, great. So in fact, because my next follow-up would have been the revenue side, so that'll be in the budget, hopefully, for the next financial year. It won't be in this financial year.
We'd expect that to be next financial year.
Yeah,
by the
right.
time we've recruited staff, it will be next financial year.
Yeah,
revenue.
okay. Thank you very much. Thanks.
Thanks, Tim, for those questions. Thank you. I've got Tony. Tony, do you want to come in, and then I'll maybe go back to Lynn if she wants to add anything to the report and give her a chance to catch her breath there. Tony?
Thank you. Just the recent announcement about the resident doctors strike. I'm just wondering what the impact could be on Humber. You know, fingers crossed that I know there's a meeting today with the BMA in West Street, and I hope it doesn't go ahead. But just wonder if there's any news, please, Michelle.
Yeah, I'm going to ask Lynn to do that in Lynn's operation.
Oh, right, thank you.
We're just going to come on to it. We're just going to come on to it.
Apologies.
Okay.
No, that's fine. It's a great question. Great question.
Lynn?
Could I just give that overall operational headlines, if that's all right, Caroline? And I will come to that, obviously, Tony. So just to remind the governors, obviously reported here before, but our ICB is under scrutiny still from NHS England around its urgent and emergency care performance overall, particularly the acute hospitals, around emergency department waiting times, around those ambulance handover times, and particularly those patients that got no criteria to reside. So that pressure is still there to improve. There has been some improvement, but obviously these are the summer months where we would expect to see improvement in that flow, which is why there is an absolute increased emphasis on that winter planning this winter. Very clear line that this coming winter has to be significantly better than last winter. And obviously those metrics are going to remain at the forefront of that sort of measurement as well, which means that all organisations, and we are too, really have to be as prepared as possible, which is really where that emergency department mental health streaming suite that's obviously in my report really comes into its own as well, where we have that benefit of moving service users away from the main ED department so they're not incurring waits in there, but actually those of you who've seen the photographs or indeed it in person, as Caroline I know and Priyanka have, you know, it provides that environment that's much more conducive to assessing people with mental health needs. So really pleased to have that. So flu and vaccinations, given the impact of winter viruses last year on staff availability and bed availability. There were significant numbers of acute beds not available last winter due to the infection prevention requirements to protect patients who are in hospitals. So really that's what's leading that influence and impetus to make sure we're in a better position this coming winter. So vaccinations are going to have even more sort of focus going forward, so hence why our flu plan is really important too. From an operational pressures point of view, we're operating at a sort of Opal 2 stroke Opal 3 moderate sort of pressure position overall, so that's positive. We're really using this time to really plan well for next winter. We had a good robust plan last winter, so we'll just be building on that as well, and obviously the system learning that's taken place over recent months. So to pick up your point, Tony, around the industrial action that we've been informed about in relation to the BMA and resident doctors, if it goes ahead, it's due to take place from the 25th of July through to the end of the 30th of July. We are using our emergency planning arrangements, standing up our tactical command to plan for that and obviously to mitigate any risks in relation to that. Kwame and the medical team are very involved in that planning, as you would expect them to be. Unfortunately, we have experienced this type of action in the past as well, so we've got that past learning, the past business continuity plans already in place. It impacts our inpatient areas primarily, but generally we are in a fortunate position that we are able to cover that. Obviously, we prefer not to have any industrial action, but we are confident that if it does come to pass, then we will be able to cover sufficiently well. But it is difficult. This is obviously over a weekend period too. So at the time of year, at the height of holiday season. So obviously it does sort of bring us some challenges, but I can assure you we are planning well for it. And I'm happy to pick up any questions.
Thank you very much. Ted, you had your hand up, Ted.
Yes, I've got a question. Do you have any comment to make on the recent NHS GP practice on GP practice services for the 3 practices that we have in the trust?
Lynn, do you want to pick this up? It's something we've just picked up at the exec management team. The data has literally just been produced, hasn't it? So we've looked at it. We're looking at the data.
Yes.
Okay, but will you be commenting it? Because I've looked at some of the data and it's not great.
We're analysing that data, as you would expect us to. We had an improvement plan in place in relation to last year's survey results. We're actually obviously be examining that plan in relation to the most recent results too. So those will be progressed through the executive management team, and obviously a new plan, if it's required, will obviously be developed in line with the results as they stand. So there is some improvement when we compare this year's with last year's results, but I think it's fair to say there are still some areas that we would expect to be in a positive position with, that we need to clearly to do more work with.
So will you be publishing any comments or not?
No, well, no, we won't put any direct comments unless we're asked. Obviously, we're going to go through the PPGs, obviously, Ted. And I think some of the aspects is disappointing. Some of it is slightly improvement. The response rate was really low as well, I think, if I remember rightly, across all 3 areas. So that's one of the things that we've really got to look at, because one of the things I think we did try to put a bit more of an effort into this year was around increasing the response rate. So I was particularly disappointed with that. I think given some of the areas that we've spent a lot of time working in relationship to access particularly, and both the work that we've done with PPGs, with service users themselves, with staff, etc. There are some disappointing results, to be honest, Ted. So we need to get to the bottom of that and just see why some of the improvement plans that we didn't do the success that we needed it to, but also to look at the areas that we have improved slightly on as well. So we will be obviously coming back to that with a bit more detail.
But this was going to be complicated by the look for new service providers.
Yes, it could have come at a better time, to be honest. But it's a national survey.
Yeah.
Thank you, Ted, for your question. Thank you, Tony. You've got your hand up.
Apologies, I've got another question. I'm just going through my notes from earlier on.
All right.
Because I've write everything down now. The recent ITV piece about Josh, the patient mental health unit, I think quite a few governors seen it, and I've just started looked at it myself. There's a query from one of the governors. Is that a question? I don't know whether we can be told this in COG, but the question is, where did Josh come from? He references a unit in there, or is that not in the public domain?
I don't think it's in the public domain at this stage, Tony. So, I thought it was a good. Yes, I think we've all looked at it. I did send it out to the governors to give you some heads up. I thought it was a good story. I think it was also positive to raise the issues as well, but they're very apparent and that we're working with as well. So, but we have responded to individual questions as well.
Thank you.
Thank you, Michelle. Brian.
I just wonder if we can be assured that it wasn't from one of our facilities that Josh came from.
No, it wasn't.
Right, okay, excellent.
I actually visited the unit on a day when I saw the ITV coverage. I actually visited the unit on the day when Josh was having his bike ride. And again, just going back to what Paul had said earlier, part of the things that across units like that one and others is looking at that culture of care. What can we do to provide that enjoyment and therapeutic value of different types of activities that suit different individuals. And apart from providing it, as you saw on the actual program, those of you who saw it, was it might seem small to many of us, but it was massive for Josh and for his parents that was facilitated and continues to be supported. Okay, any other questions? Tony, are you still got your hand up? Have you got another one? No. Okay. Okay. Any other questions on the Chief Exec's report? Okay. Thanks very much, everybody. Let's move on then to the sorry, have I missed someone?
Long-term plan. Do you want me to give you some headlines?
Oh, sorry, Michelle. Long-term plan. Apologies. Sorry.
I'm very, very, very conscious of time. I don't want to run out, but I just want to give some very quick headlines because it would be remiss of us not to do that. But we will put a development session on for the governors. As you know, 3 shifts that were made on the back of the Darcy report: hospital to community, analog to digital, and sickness to prevention were key in the plan. So from hospital to community, they're looking at the restoration of GP access. I mean, we've touched a little bit around that already today about avoiding this 8 a.m. rush to the phones. A GP-led neighbourhood health service, which we are looking at. The London model has been alluded to before, but we're looking at how we can do that within the integrated care system in some of our places. Care closer to home, all this links into the neighbourhood developments, including the redesign of diagnostic services, which is in the plan. And then there's a big push on redesigning urgent and emergency care. And again, that links back to what can we do within the neighbourhoods. So there's lots of work to continue there, but builds on some of the work that we've already started, both within our community services, our mental health services, but within our integrated care board. Analog to digital, there's been a lot on there around the use of NHS app. A lot of use of doing some more work and training and support to staff around. I think the word in the document, if I'm not wrong, is about liberation of staff to utilise digital more and digital first, and to have things like the single patient record, which obviously builds on some of our work that we've done with Interweave. Only headlines this, I can go into more detail when we have the development session. Also, sickness to prevention, and that's about physical activity, all the work that you would do on that preventative piece, and lots on children within the plan. I'm doing this mainly from memory. There was also the devolved operating model mentioned, and that's around the work we've already started and we've touched on around the model ICB. So reducing the size of ICBs, looking at how regional offices work, and this abolition of NHSE from that central control. There's also things in there around foundation trusts, to go back to endorsing trusts as foundation trusts, about re-registering current foundation trusts, and the issues around how they're governed and the governance process of that. Bits on multi-year financial forecasting and trying to reduce the bureaucracy within the systems. And there's a mention of a new charter for patients, but also, as you know, this abolition of Health Watch. Quality is underpinned. Obviously, there was a DASH report that isn't mentioned in the long-term report, but you need to read them both together. And that's about looking at outcomes, but also about that high-level incentives for good quality care and more power to patients and utilisation of the patient voice as well. Workforce, we mentioned a little bit around reducing the workforce. So we're waiting for a 10-year plan to come out. We're waiting for the delivery plan as well of this particular plan, but I think key to it will be the 10-year workforce plan. And there has always been this push on reducing the reliance on international labour that is contained within the plan as well. There's a lot more, I'm just literally skipping over it. A bit, I think if I remember right, on innovation to drive reform, and looking at research and strengthening the research environment and how we really link into utilising that research to give it the biggest impact. And what was quite interesting, I think, was the global institutes that were mentioned, and that links into some of the work that I've been doing with the research network. And then it goes into what that means for individuals, what that means for individual conditions, etc. There's a lot in there. The devil's in the detail for me. There isn't a delivery plan associated with it yet. There's 6 work streams that are around those key areas that I've more or less identified. Are we being asked, and we are participating, or we will be participating in those work streams to develop the delivery plan? The ICB has already started to look at its footprint and how that works. We know that there's going to be, I think, 26 ICBs as opposed to 42. Humber and North Yorkshire will still remain an ICB, so that's good for us. But we need to think about how that works with neighbourhoods, how it interjects with the places as well. So I think what I'm trying to say is that for the next 12 months, there's going to be a huge amount of transformation and change. And we have to continue to work within that, influence it, support it, but also deliver the objectives for our staff and our patients, more importantly. And we'll continue to do that. So we're just unpicking all of that. We can't unpick the delivery plan because we've not got it. We'll shape that as much as we can. There's been a lot of talk, lots of conversations with the national team that I've been involved with, but we'll put a development session on and then we can have a bit more conversation. Hopefully by the time we get something together, we can have a bit more idea of what the delivery of that plan is going to look like and what the targets will be for the organisations as well. But what it means for patients and what it means for staff is important. And the whistle-stop tour on the long-term plan. I'm sorry, Chair, but I thought I'll leave it there, and I'll try and answer any questions.
We will have a development session, so I don't want to take too much time up now. But Tim,
just as a comment quickly, I mean, of various things bothers me. I mean, years ago, I was very sad at the abolition of community health councils. Then now we're talking about the abolition of Health Watch. And as I understand it in the plan that you've just mentioned to us, abolition of our role in foundation trusts is a possibility stroke probability. And I just wonder why all the time it is that way it's going rather than the other way. Just as a comment.
Yeah, we fed that in, Tim.
Thank you, Tim. Anybody else? No. Okay. Thank you, Michelle. Right. I suggest we take a 5-minute comfort break now. So please stay on. Can we stop streaming, please, whilst everyone gets 5 minutes for a comfort break, and we'll be back at about 8 minutes past 3, please. Thanks. Okay. James, can you? Hello and welcome back to Humber Teaching NHS Foundation Trust Council of Governors meeting this afternoon, and we'll go back to the agenda, and we're on item 8, which is the non-executive directors, chairs of subcommittees, assurance reports and feedback. So I will work through the list. Steph is on holiday, unfortunately. Stuart is also on, can't be here, but he's sent a recorded video. Phil, could you start for us, please?
Sure, thanks. This quality assurance report that was presented to the board at May relates to actually meeting in February, but just to assure you that we meet 5 times a year, so quarterly plus an extra meeting to look at annual reports. Because it's quite an old report, I thought I'd probably just really briefly just use it to tell you the type of themes that we look at. So firstly, we scrutinise reports that are going to go forward to board and so prior to board. And an example in this agenda was quality accounts and the board assurance frameworks and risk register relative to quality issues. Then we look at policies, and on this agenda there was sexual misconduct policy and complaints and feedback policy. And then we look on behalf of the trust at any quality issues raised by national issues in mental health. An example on this agenda was the Nottingham inquiry. And then obviously we always look at performance. And on this agenda, we look quickly, particularly at Q3 waiting list performance. And then we look at changes needed to strengthen the quality of our care. And we wanted in this meeting to understand the impact of the new medical examiner regulations. And also, when there are changes in policy, we want to be assured that the training is in place to make sure that the changes in the policy are well implemented. And then the last thing I just want to highlight is that we also look at anticipated changes to try to see and ensure that the trust is well prepared. An example for this would be on this occasion we were looking at Supreme Court judgment in the definition of sex. And I just thought I'd frame it that way just so you see that we actually try to look at different areas that help us in our duty to assure the board that the quality of care provided by the trust is excellent and appropriate and improving.
Thank you, Phil. When's your next meeting, Phil?
So we had one in May, and the next meeting is on the 7th of August.
Okay. All right then. So maybe when we come to October, Council of Governors, we can look at how those meetings are then reflected in the report to the October Council of Governors. I think that'd be really helpful. Thanks, Phil.
Sure.
Any questions to Phil? Ted?
Yeah, just one question really. I was wondering whether the High Court judgment about the involuntary manslaughter decision, a verdict on the lead nurse in a mental health facility, that the first time this has happened, somebody was found to be responsible for the care of the patients. Has that had any effect? Do you actually know what I'm talking about?
I do know what you're talking about. But
sorry, Phil, sorry to talk over you. I've got to see Sarah's hand up there. Yes. Phil.
No, I was just going to say, Sarah will be the best place to give you the truth.
Okay, thank you, Sarah.
Yeah, thank you for your question. We took a sort of paper into our sort of development session because it had just sort of gone public a couple of weeks ago, where we did sort of consider it as an executive management team and a board. So we've kind of approached the initial sort of review is the things that we need to consider as an organisation, and is there any imminent risk sort of for ourselves. So that's the way we've initially approached the report. Obviously the report is about the sad sort of death in relationship sort of to Alice. But obviously plastic bags have been a prohibited item within our trust for well over sort of 10 years. We're kind of watching the case, Tim, really. Obviously, there's further work that's going to go through the courts and that. We've kind of highlighted it with our clinical leads as well, to have those sort of conversations with our Band 7 ward leaders as well, because this could have a kind of a negative ripple effect with our sort of clinical leaders. So we're making sure that we're having the sort of supportive conversations there as well. So it's a continued dialogue, really, and I think we'll continue to discuss the case as more emerges nationally on this one.
But my understanding of it is that the individual ward manager now becomes individually responsible for his or her action. Is my interpretation right?
It's correct. That is correct.
And that, for somebody working on the ward, is worrying.
Yeah, it's this case is kind of going to set quite a bit of precedence if that is the sort of final outcome on that. So we need to see and understand how that evolves and emerges. There's lots of conversations happening at a national level in relation to this case, and understanding how that case got to that degree where a Band 7 is held culpable ultimately. So there is more to evolve on the case nationally. It's something as sort of directors of nursing that we're watching very closely. It's something that we'll continue to review, but could set precedent and could, as I'd said, create a ripple impact across our sort of clinical communities.
I just think that the staff may actually refuse to work.
Well, I don't think that's appropriate to get into now. I think suffice to say, has been explained, Ted, is that when we had a strategic board meeting, at the end of last month, this was an issue we actually discussed. As Sarah said, it will be taken forward. This is a good example, Ted, of when something does happen that is clearly serious, or when the end of a process of investigation happens, that across, in this case, mental health trusts, everyone has to look at, the centre will say, have you looked at yourself? Are you reviewing? And often it's before any direction actually happens. So another example of that would be Edenfield a year or so ago, in terms of some practices happening in that unit. The Nottinghamshire situation with the deaths of individuals by a known patient to the services there. So again, across the sort of sector, if you like, these are things that happen on a regular basis. And there is obviously, we don't wait for guidance. We look at our own services and what we're doing straight away to do a check on those. But again, ultimately, decisions will be made at the centre about how these things might happen, and we'll input to that. Michelle, anything else you want to add on that? I saw your hand up before.
Yeah, no, I don't want to prolong it, but just to say, because obviously it's more a board and operational issue. Yes, it is setting precedents, or potentially could set precedents, but it is under the Health and Safety Act. So basically, this has been available for a long time, since the latest reiteration of the Health and Safety Act, where corporate manslaughter or corporate criminality was stopped within individual boards or accounting officer like myself, but then altered so that it could be apportioned out to key individuals that had accountability and responsibility. It's clearly never been done in the NHS in this way before. It has been done in other industries where individuals have been identified. This is the first time it's been identified within the NHS about potential criminal responsibility being taken at Band 7 level from a ward manager point of view. So Sarah rightly said there's a lot of implications as to how it got to that level, etc., etc. But yes, you're absolutely right. It could really affect the ward leadership type bit, which we are looking at anyway. We're not waiting for guidance, we're looking at that and supporting our team leaders as well. But we feel we've got enough processes in place to be able to support staff currently anyway, with any incident, the processes that we've got. But it will be an interesting case to follow through and to watch, and we are doing that.
Okay, thanks very much. And just for this streamed public part of it, this incident did not happen at Humber that we are talking about this afternoon, but clearly we're mindful of it and are engaged. Okay, if there's no other questions on the quality committee, I think we can move to the next one, which I think actually is mental health ledge. Now, Steph's on holiday. I don't know whether Dean or anyone who was at that meeting would like to add anything, or if anyone's got any questions we can take away from that report. No questions to that? Comments? Okay. Stuart, Katie, could you share Stuart's recorded video, please? You put the sound on, Katie. I can't hear that. Can anyone hear it? No.
No.
Right. Okay, let's stop that. Let's stop that. And Katie, if you can try and look and sort it out, we'll go on to the next report. Keith.
Hi, Caroline.
Thank you.
So me in person rather than a video. This is a report from the Finance Committee meeting that was on the 15th of April and then came to board, as you can see, at the end of May. And like Phil, I hold 4 of these a year. We in fact have one on Tuesday this week. So we've had a more recent one literally on Tuesday this week. I think the key areas on this was just after the end of 23-24 finance 24-25, I should say, actually 24-25 financial year, and we had a really good break-even position at the end of the year. As you can see, a very small surplus, but not material, but a very good break-even position. I think continued conversations in the committee about the wider ICS system and the finances and the strain that potentially brings to the organisation, both at a system level, but also for us as an organisation. And that situation obviously continues into 25-26 and onwards. So that situation hasn't resolved. And we continue at each of our meetings to talk about the implications of the system and what that may have in how it plays on Humber and us as an organisation. The real focus, I think, was probably around how, as a committee, we start to really focus on productivity and efficiency. Both words meaning slightly different things, but this is a real focus around if we're spending £1 of the NHS's and the public purse's money, are we very clear on the return that we get and the value that we get for that £1 that we spend? And could we be more efficient, or could we deliver a better level of productivity if we did that in a different way? And that's proving to be an area of key focus for NHS England and the centre, and certainly will become a key focus for us as an organisation. And at Tuesday's meeting that we just had, we looked at the first review of that from the executive management team, and Pete and his team from the finance team, as to how we start to look at those measures around productivity and efficiency, and how we triangulate those across both with other organisations, similar organisations to us, but also potentially with central NHS England measures and their view on productivity, and how we triangulate all of those together as an organisation. So we have much work to do in that area. And to that end, we've just agreed actually that we're going to relook at the agenda for the Finance Committee moving forward, and really look, because we're an extremely well run and very robustly run finance organisation. So it's not that we don't want to spend time talking about finance, but we do need to make sure we have enough time to talk about things like efficiency and productivity, and also an increasing focus on digital and the time we spend talking about digital and digital within the trust. Digital has always come to the Finance Committee, but I think it needs to have a greater audience and a greater time to be able to debate it in more detail. So we'll see more of that moving forward. Overall, a very positive financial situation, and as we've moved into this year, the 25-26 year, that financial strength has continued forward. So a good position, but as always, a lot of focus and a lot of system and NHS England focus around how we spend our money and how wisely we spend that money.
Thanks, Keith, very much. Tony.
Thanks for that, Keith. Just for clarification, it says matters of concern or key risks in the report. The requirement to reduce trust corporate costs by 50% over 25-26 financial year. Is this referring to the ICB, or is this a...
No, it's referring to all trusts. And to be very clear, I've worded that in a way where you could read that in a number of different ways, in fairness, Tony. What it actually says is it's to reduce corporate costs by 50% over those. So that increase from the 2019-2020 number. So if we spent this much in 19 and 20, we spent this much in 24-25, we have to reduce that by that difference by 50%, if that makes sense. So part of the work that Pete's already done on his team is actually getting to an agreed number. Because, for example, as an organisation, we do a number of things. We host, for example, a number of digital systems for the whole of the ICB. That creates a level of structure and obviously cost that goes with that. So we need to be very clear that we're working on the right numbers and we're working on the right structure, if that makes sense. In our current BRS plan at the moment, we would deliver that requirement in the current plan at the end of this year. So we are on track to deliver that. But that isn't to reduce our whole corporate cost by 50%, right, if that makes sense. Okay. It's the growth. There has been in the NHS quite a significant growth in that corporate cost. And NHS England is getting trust very focused on pulling that cost back, if that makes sense.
It does. Thank you. I thought I'd better clarify that. That's helpful.
No, please do. With hindsight, I worded that somewhat vaguely, so my apologies.
It's okay.
Thank you. Thanks for both the question and the answer. Tim.
Just a comment again, and that is it's great to see that the agency spend and agency costs are being reduced by the percentage they have been, because this has been remains a big problem, but has been a big problem. And I see special note to Dr. Fofi regarding recruitment of vacant consultant posts, because we have been very short of consultants, and it's great to see that that's an improving situation.
And I have to say, Tim, having had a meeting this week, that continues to improve and that trend continues forward. So the progression in the last 3 months has continued that trend forward as well. So it's a continuing positive situation, and our agency use now is very, very minimal.
That's great. Thank you.
Thanks very much. Any more questions to Keith? Can't see any other hands up. Thanks very much, Keith. Dean, let's go to you.
Yeah, thanks, Caroline. The report is there. Just a couple of highlights. As always, we get chairs logs from the staff health and wellbeing group, the equality and diversity group, and also the medical education committee. And I suppose just pulling out there, really pleasing to see the positive results that we got from the national training survey and the GMC survey that showed 80% of the sort of resident doctors that we're training would recommend the place as a trust to get care, and also slightly higher than that as a trust to receive their training. So really positive there. We also got the People Insights report, so maintaining lower vacancy rates than we've had, and turnover still below 10%, and strong position around our statutory and mandatory training. And you'll see a bit later on in that as a result of some of those reductions in vacancies that Tim's also highlighted on, we've seen a reduction in the risk score that we've got around those vacancies. It is still an area of focus for us, because we still need to do more, but they have come down significantly over the past 3 or 4 years. And I suppose it's worth highlighting, I mean, Jackie picked up earlier about sort of workforce reductions and a lot of sort of national discussion around this, and I think people sometimes conflate different things between, reductions in establishment, i.e., what you're funded to do, and reductions in staff in post, and those can be two very different things. So for us, where we've still got a gap between our establishment and our staff in post, then really important that we're looking at that gap in between the two. And Tim, you've also highlighted there that sort of reduction that as we've filled some of those posts, we see that reduction in agency spend that sort of is filling that, the bank and agency spend that fills that gap. And then just one final thing, I suppose, just to highlight that we've thought in terms of sort of continuous improvement. You know, are there things that we should be spending more of our time focusing on, given the sort of changing agenda? And as Keith highlighted on, and we thought we need to be doing more in this committee through looking at sort of workforce productivity, given the conversations that we've had. Also things like workforce planning, education and training, given the long-term plan coming out, and a new workforce plan coming out in September as well. So we've just had a forward look about what we want to refresh the agenda on. And it's also that time of year where we do lots of sort of governance stuff. So we approved a whole lot of terms of reference for some of the committees that report in through to the People and OD committee. But happy to take any questions.
Thanks, Dean. Any questions to Dean? Comments? Good. Thank you very much. Have we got the Stuart video able to be shown, Katie?
Yeah, we're going to try it again, Caroline, a different way. Yes.
If not, we'll abandon that and we will send it out with a link to everybody. Okay, let's have another crack at it. I'm not hearing anything. No, let's abandon this. Katie, can you stop it, please, and get us back to the gallery screen?
Busy.
Oh. Okay. All right. Are there any questions on Stuart's report that we can follow up or try and answer today? Tim?
Well, I was concerned about the business of the fire alarms at Whitby Hospital. I mean, I don't know how serious a problem it is, but clearly it's been highlighted, and I just wonder if there's any more information. I was also rather surprised, I think it was in an earlier report, maybe it was the Chief Executive's report, there's scaffolding up there for repointing work and everything. Well, we only just got it back from the builders a couple of years ago. I'm surprised that work needs to be done, but just comments and queries.
Thank you, Tim. We actually did have a sort of follow up on that on the board around the fire situation alarms. I think Pete can deal with both those issues. Pete.
So very quickly on the pointing, Tim, that is an NHSPS building and had some work that needed to be repointed following the completion of the construction. So we're just working as a tenant of that building with NHSPS. It's not a scheme that we're actually administering ourselves. And I'll put some more detail in the chat box, but the Whitby fire alarm, we did do a note after the committee because there was a bit of confusion. But for assurance of governors today, the fire alarm at Whitby works as intended. It's a cause and effect system. Our fire officer, the North Yorkshire Fire and Rescue Service and the NHS Property Services Fire Officer have all been up to Whitby and are content with how that alarm system works. And indeed, we've provided some training to staff and actually observed fire evacuation exercises. But I'll put more detailed notes in the chat box.
Yeah, thank you very much, and that's great.
Thanks, Pete. Thanks, Tim, for that question. I can't see any other hands up from governors. Okay, thank you. We will now we'll move on then to Jackie. Jackie's going to give us a sort of a little bit of an overview of her work at the university and how it relates to Humber. I think we've got some slides as well, Jackie, which again we'll share with people later.
It's all right. I'll share my slides because I'm in control of them. I've sent a PDF. I like to be in control. You probably realise that. I've sent a PDF to share with everybody in case they needed to see them in advance or afterwards. So let me just see if I can sort my screens out, and hopefully you can tell me if it's come through or not.
Yes.
Okay, brilliant. Now I've got about 10 to 15 minutes. So I'm trying to be brief. And what I'm
going
to do
is...
Can
we make it 10, Jackie?
Okay, I'll keep an eye on the time. You might have to give me a 2-minute warning or something.
Okay, I will.
So, yeah, I've been the appointed governor for the University of Hull for a long time, and it might even be my final year or coming up to the end of it. So it's about time I talked about partnership. So, yes, University of Hull. Just to highlight, we're one of the oldest universities and still quite a big employer in Hull in the region, although we have had some reorganisation. We're highly rated for teaching excellence, and we've got these specific areas of research which we really lead on, and particularly interesting to Humber, I think, is addiction and mental health, exercise and rehabilitation, and I'm going to pick out some of the highlights. So hopefully you know where the University of Hull is, but it's an unusual university because it's now all on one campus. We used to have a campus in Scarborough, which we sadly gave up to Coventry. And we've got this fabulous campus. There's a picture of the campus. You're welcome to come and visit us. And we've got 4 faculties in the university. They're about to shrink to 3. Faculty of Arts, Cultures and Education, Faculty of Business, I'm going to get this wrong, Law, flubberlub, I want to call it. Law and Business, Faculty of Science and Engineering, and the Faculty of Health Sciences. And I'm going to speak about the Faculty of Health Sciences because it's the Faculty of Health Sciences that provide your workforce and are most involved with research and enterprise in the trust. So we're, like I said, major contributors to the region's healthcare workforce, and we've got some cutting edge facilities. And there's 4 schools in the Faculty of Health Sciences: Psychology and Social Work, Sports, Exercise and Rehabilitation Science, the Hull York Medical School, which is a weird entity that exists between the University of York and the University of Hull, so it has some unusual governance arrangements. And we have Hull-based MBBS students here in Hull, and some of them are registered at York. And then this massive school that I have now that has merged 2 schools together, which were called Nursing Midwifery and PPAP, which is Paramedical, Perioperative and Advanced Practice. Now, this is such a mouthful. You'll be pleased to hear that it's going to be called the School of Healthcare on the 1st of August. And my title and everything at the bottom will reduce, which I'm really pleased about. So, give you a bit of a flavour of what we do. Mostly in the education space. I've just and highlighted some research issues. So the psychology and social work, if you have a look at these things on the screen, at the bottom we've got the clinical psychology doctorate, the mental health and wellbeing practitioner, and cognitive behaviour therapy preparation, which are the things that are most involved with Humber Trust. The Trust is a host employer of clinical psychology doctorate student. They're trainee psychologists on Agenda for Change Band 6, and it takes 3 years, and it's an unusual course because if you start as an undergraduate psychologist in Hull and you do well, you can apply for this. There's 100% employability, and in 2023 and 2024, 9 of these psychologists who graduated went to work in the trust, and the partnership is really, there's teaching as a partnership. So an example would be in October, the clinical psychologist working with the learning disability specialist services, they facilitated a 3-day workshop for our Year 2 doctoral students on best practice in working with people with learning disabilities, their carers and families. So a bit of a flavour of that. In terms of sports, exercise and rehabilitation sciences, I'm just picking out the physiotherapy and the nutrition and dietetics programs here. 60% of dietetic graduates and 90% of physiotherapy graduates are employed in the Yorkshire and Humber region when they finish their course. And we have a number of dietitians and physiotherapists in Humber Teaching NHS Foundation Trust who teach as external lecturers. So, for example, eating disorders and bariatric training for student dietitians, and involvement in a learning disability and careers fair for physiotherapy students. And 10 physiotherapy students attended Humber last year for clinical placements. And there's dietetic placements in mental health and catering, amongst other areas, which sort of makes sense. And we heard about that when we heard about Inspire, didn't we? And the role of dietetics with eating disorder patients. In terms of the whole York Medical School, like I said, it's in partnership with the University of York. There shouldn't be a gap in the MBBS medicine, which stands for Bachelor of Medicine, Bachelor of Surgery. I had to look that up, you know, I should know that after all these years. It's always MBBS. I've greyed out physician associate because I don't know if people have been keeping up with the news, but it appears they're going to be called physician's assistants. So I think the name's going to change. And there has been a bit of a suspension while that report and investigation was going on. There's a strong partnership with Humber, with mental health and some primary care placements for these student doctors on their rotations. And there's also with the doctorate in medicine, the medical doctorate, there's quite a lot of clinical research undertaken. There's 19 MDs in Hull at the moment, registered at Hull. And we've just approved some regulations for NHS clinical staff with honorary status at HIMSS to apply to be principal supervisors of PGR project, postgraduate research projects. We think it's going to strengthen the relationship further. I bet I've nearly done 10 minutes. Now I'm getting on to the schools that I know best. This is my enormous school. I have 73 staff. It's the biggest school in the whole university, and 381 students across all of the cohorts of 25 programmes. There's 250 modules. So we have this really unusual programme called the University Certificate Alternate Route into Health and Social Care. And I was thinking about this when Paul was talking about the peer supporters. This is a programme that enables we're really proud of this. There's 666 students studying this at the moment. You can come to the University of Hull. It's like an access course without any qualifications. And our staff from my school will prepare you. And if you do well, which many do, some graduated yesterday with first-class degrees in nursing, you can go on to our health professional programmes. So it's very good widening participation route. These are the programmes that we have. Our student satisfaction results, which came out at the beginning of the week, have been absolutely fantastic. We're really proud of them. In terms of Humber, we're really placing our mental health and learning disability, but also I'll move on to the next screen, our community nurses within your organisation. We have really strong relationships because there's 50% practice learning of these programmes. So we work really closely with your practice educator team. So there's Kate Baxendale, the Deputy Director of Nursing, and the lead educator, Melanie Barnard, I want to call her. I think it's Barnard Blythe now. And we meet regularly to try and solve problems. And we have apprentices as well in the trust. So these are the other programmes in my school. And as I say, the specialist community public health nursing. So we've got school nursing, health visiting, district nursing. So district nursing and health visiting, we do have placed in the trust. At the bottom here, we've got some of the programmes for registered nurses that are and allied health professionals that they take a CPD. So we've trained a lot of non-medical prescribers in Humber, and we have this professional nurse advocate, and we've now got one for allied health professions. And we also run smaller workshop type programmes to meet needs such as vaccinations and immunisations for staff to update themselves. We've got the most fantastic facilities, and as I say, I'm going to circulate the PDF so you can do a bit of a virtual tour by clicking on these links when you get that. In terms of research highlight, I'm on my final slides now, Caroline, because I'm talking very fast.
Thank you.
We've got recently funded by £11 million NIHR grant for the Centre for Addiction and Mental Health Research. This is fantastic. And we've also got the Institute for Clinical and Applied Health Research. And we've got a clinical trials unit, which means, I mean, that's really important for us to win big grants and be able to do projects within the trust. And obviously, over a number of years, there's been a lot of different types of projects. That we had a long history of dementia research, which sat in psychology with Professor Esme Cook. But we're really moving into this addiction and mental health research. We've got Tom Phillips as a professor there. We're working across Hull York Medical School and so across York and Hull, and we're really proud of it. So we're collaborating with Humber on a number of PhD studies and multiple research projects related to addiction. And perhaps most significantly, we've got a formal collaboration agreement regarding the Centre for Addiction and Mental Health, which was launched a few months ago. And we fund the release of two co-investigators, Dr. Hannah Armitt and Dr. Laura Voss, from the Trust to participate in this research. And Hull York Medical School, the University of Hull, and the Trust are developing a joint appointment for a professor in addiction psychiatry. So really exciting work that's going on in this space. Yeah. So other research highlights and enterprise highlights I've got up on the screen here. I would point out my own work, which was the which has led to the use
Jackie,
of
we're going to have to come to close.
Physical health and serious mental illness assessment tool, the HIP, which has been used for years. And okay, I was just, there's a couple of slides about some projects that are going on, which are in Humber by student, PGR students and psychology students. And that is my final slide.
Thank you. Thank you very much, Professor Jackie White. Thank you very much.
To stop sharing.
There's a lot there. People have access
too much, I think, for that presentation.
No, thank you very much. And if anyone's got any questions when they've had a chance to maybe look at the slides in your own time, then I'm sure Jackie's happy to answer any questions. So thanks, Jackie, for sharing that. Great work.
Thank you. It's a lot. I was just trying to give you some highlights.
That's fine. That's fine. Thank you. And good to see addiction and mental health dual diagnosis is featured there. It's really important.
Caroline, we don't like the word dual diagnosis.
Oh, don't we like that? Am I old? Is that old school?
I think I'm a bit old fashioned with it because it suggests it's something different and actually it's usual. Okay. So if something's dual diagnosis, it sounds like it needs a separate service, and you can reject people from your current services. Just about everybody in services have addictions and they go hand in hand. That's my challenge of the day.
No, thank you very much. I think the dividing line between those two some years ago when I was involved in it, it's like 16 years ago, was reason why it was pushed so much forward and trying to get that, seeing the holistic issue of that issue. So it's good to see that work being taken forward. Thank you. Right, okay, look, we are coming up in quotes at time. I can extend the meeting a little bit, but if we can work through and the reports that are on there, if we just go straight to questions where it's appropriate from governors. So let's move on. Thank you very much, Jackie. Obviously, Marilyn's poorly. Tony, would you like to say anything about the last engaging members group that met?
Just very quickly, we are in the process, we've tried several times, we're having another go, to review and update the membership plan. Still concerned about the numbers of governors who attend the engaging with members meeting, so I'd encourage all governors to attend. We've had discussion about the annual members meeting and our involvement in that, which has gone well, and there's been some changes to that. And I think that's it from engaging with members.
Thank you very much. Any questions, Tony? Great, and please make sure you've got the date in your diary for the annual members meeting in the autumn, please. You're all very welcome. If we can move on then to governor questions, anything not already covered on the agenda that people would like to raise? No. Okay, right. Thank you very much. We'll move on. We have two reports on the effectiveness review for the engaging members group, and also it's missed off the agenda, the appointments, terms and conditions group as well, which you have got a paper from. So I will just move, I think, to both of those. Are there any questions on the engaging members group paper? No. Are you happy to approve that report? Yes, thank you very much. And on the ATC committee, are there any questions on that one? No. Is the Council of Governors happy to approve that report? Great, thank you so much. Thank you. I'll go to Stella. Review of Constitution, please, Stella.
Yes, I'll try and be brief. Caroline, there's just a proposal there to make it more explicit about who approves the affixing of the seal. It's based on legal advice that we've had in relation to our standing orders, scheme of delegation and standing financial instructions, and it just tallies the two together by making this change within the Constitution. If the Council of Governors does approve this, it also needs to go to the board for approval.
Thanks very much, Stella. Any questions to Stella on that proposal? Can I see all those in favour of that change to the Constitution? Anybody against? No, thank you very much. As Stella said, that will go to the board. Jackie, you got your hand up, sorry.
Yeah, no, that was an error of my tremor.
Oh, right, okay.
Clicking on the wrong thing, sorry.
All right, thank you very much. I haven't been notified about any other proposals or changes to the Constitution. So that one will be going forward to the board for approval in order to make the constitutional change. Thanks very much. Trust compliance with fit and proper person test framework. I'll take it as read. Are there any questions? No. Okay, that is noted. Compliance against the provider license. I'll take that as read. Are there any questions? Oh, sorry, Isabel. Sorry, was that for my one or for the next one?
No, it's for the provider license one.
Fine, thank you.
It's just in decisions made on the front sheet. It said a decision was made at the board meeting on the 28th of September 2025. I presume that's May because we haven't got to September yet.
Correct. Correct. Okay, thank you very much. Can we get that amended, please? Thank you very much. Can board support unit please check the front sheets for any dates and misses, things like that. Thank you, Isabel. I'd like to say that was a test. It wasn't. It was a mistake. Thank you very much for pointing that out, Isabel. Okay. Any other questions on that? Thank you very much. That's for noting. And we move on to the performance and delivery report. Performance report, Pete.
Thanks, Caroline. I'm just going to suggest, given the time, we go straight to questions rather than me talk for 5 minutes.
Perfect. Thank you. Questions to Pete or Lynn, for that matter, probably. We've covered some of this earlier. Isabel.
Yeah, it was just a question about the staff sickness levels, because I know it's something that's come up before, and there were quite a lot of units that were down as red flag units. And I see that there's going to be a targeted bespoke intervention. So it was just to ask around what assurance the board have around the targeted intervention and what the intended outcomes of that intervention might be. Thanks.
Okay, thank you very much. Who would like to deal with that? Dean.
Say it's probably for me, isn't it? It's yes, we've discussed it, Isabel, at the workforce committee. So we've had that sickness absence that's been stubbornly sort of where it is, and important for us to sort of drive down on it. So we're just trying to get some more interventions in terms of what's going on in particular areas of where there is high sickness absence, to have a look at the reasons for that and the targeted support, and to report back through the people committee on the work going there. But also, we do lots of things in terms of things like health and well-being, for example, to support staff. So we've been curious at the last couple of meetings about are those things being accessed by staff who most need it, if you see what I mean. So you can do lots of sort of activities for people that are otherwise fit and healthy, and great that they take advantage of it. But often we're providing these things to support people to reduce stress or sort of work in a more resilient way. So so we're hoping to get more sort of detail through the workforce committee on those interventions, the impact that they've had or otherwise, and what we need to do if they're not having an impact. So I hope that gives you some assurance about us sort of working on that. It's also an area I think that will have increasing focus, because it's going to be one of the areas I think that when trusts are segmented, that they'll have a look at sort of sickness absence rates for people as well.
Yeah, thanks for that, Dean. I think when you've got an area where you've got sickness absence, then the other staff are more under pressure. So paradoxically, they're less likely to take up the opportunity for the health and well-being because they're just focusing on the jobs. So it's getting out of that spiral.
Yeah, thank you, Isabel. Tony.
This isn't a question about any performance issues as such. It's a request from governors that to ask. I'm sure we've raised this before. Is that can we please have the full performance report included in the papers for Council of Governors, please? Our feeling is that this is probably the most important report that we see and view, and we'd like to see the whole report back in the papers, please.
Well, the link to that is in the agenda to the full board papers, which you all receive. So the latest iteration of what's gone to board was May. The next one will be at the end of July, and you'll pick that up. So all those papers that we've seen and therefore available for you to look at and comment on in the detail are available. So I don't know if let's sort that out offline if there's a bit of confusion there, because they are all provided to aid that understanding. Rather than doing yet another set of papers, you've got the latest papers that have come to board. Does that explain it, Tony?
Well, yes, but I'm not asking for another set of papers. I think we're asking for the same, but just
you get them. You get them though. You do get.
Well, we only had them. Some of us only had the papers on Monday, and some of us only had them yesterday.
Okay, there's a link to all the papers. I'll let me take it offline. It's all available.
All right.
We maybe need to join up the dots to make sure people know where they are in the packs in order to open them up. So I will definitely take that away, but they are available. Thanks for the question, Brian.
I was just going to support that notion because I received the papers yesterday, so it doesn't give much time to get to this section and then go on the link and download them from the link is an extra.
Okay.
And it would be useful, I think, to have those papers with the agenda.
Okay. Well, nobody should have been receiving.
Hang
on a second, Michelle. Hang on a minute, Michelle. Let me take away about the papers because nobody should have been receiving all the paper packs yesterday as well. Okay, so let me take that away, Michelle.
Yeah, I was going to say that about the paper packs. The issue with the paper packs is that obviously we're trying to stop using paper, and there's a security risk alongside everything else. And obviously because they go out a week in advance, that's why sometimes it takes longer because we're not control of the Royal Mail system. So that is a problem. All the performance data reports are on our board reports and are on various links as well. So they're constantly updated. So you can see them from the board pack. So they're not. I don't think you're missing out on anything because all the information's there. And if you remember, we've had this conversation several times about do we or don't we increase the performance report, and it was a discussion from the governors that you didn't want the performance report as it was, you wanted an executive summary. So that's why we put the link in and do the executive summary. But the packs go out exactly the same time as people or get them on the electronic system. It's just that the Royal Mail take whatever time they take to deliver them. And we send them the most expensive mail we can do, but the issue is we shouldn't be posting them out. And as people will know around the table, I've got an issue about people having paper because there is a security issue as well as a financial implication and a cost and a time implication for the team. And also the fact that you get it later than everybody else.
Okay.
I agree with Michelle. I don't think we should be using paper. I think it all should be via email.
Yeah, thanks, Turner. It's a lot safer. It's a lot safer.
And save some money as well.
Okay. It saves a lot of money, actually. We have costed it out.
Okay. Let's not have that. I actually think for some people, and that includes myself, I like a paper version. But there are logistical issues around getting the paper version out in time. That's why everybody receives the digital version, in order that they can look at that in advance. So that's what I do. It helps me chair meetings to have a paper version, but I look at all the digital stuff before then online. But anyway, let's sort that out. Anthony.
I noticed that the trust's vacancies are currently 7%. Is that of concern to the trust? And also, how difficult is it to fill those roles historically?
Who'd like to start? Dean?
I guess I'm happy to pick it up again, Anthony. So yeah, 7%. The vacancy rate. So the vacancies is between our budgeted establishment, so the number of staff that we are budgeted to employ, and the number of staff we've actually got in post, and that's a 7% difference. But that has been coming down year on year, and that's why I think in my assurance report I said that we'd reduce the risk rating that associated with that, because it is narrowing. So it has been up at 12 and 15% if you go back a number of years on there, and it is through recruitment. So this isn't a case of, you know, some places will hold vacancies to save money. In our case, it's about trying to recruit people into posts, bearing in mind that we've got turnover and new sort of posts coming. Some of those are what we would call hard to fill posts, so some of the consultants where there's a limited number in the country. Not for the want of trying, but where we have got those vacancies, those are often then filled with bank and agency staff to cover the gap between that sort of establishment. But you can see part of the reason that the agency spend is coming down is because we are narrowing that gap on the vacancies. So yeah, it's always a concern, but it's also a positive assurance that the gap's narrowing, if you see what I mean.
Okay, thank you.
Thank you. Thanks for the question. Any other questions on the performance report? No. Okay, let's move on to finance report. Are you going to take that as read, Pete?
I will, Caroline, and we've had the Finance Committee Assurance report as well, haven't we, which covers quite a bit of this content.
Perfect. Thank you. Any questions or comments? Oh, okay, fine. Okay, we had quite a few questions as earlier on, and we had obviously had Keith's assurance report as well. Okay, thank you very much. I haven't got any other business brought in front of me. So review of the meeting. Do the governors feel that we've focused on the right areas in the agenda today? It's been quite a broad-ranging number of items that we've had a chance to delve into. Are people happy with that? Thank you for that thumbs up, Tony. The quality of the papers, were you able to perform your role effectively? We'll take away the fact that's been mentioned in the last item around getting papers in time and some of that, and also where to find the actual performance report in detail that the board receive as well for governors. Is there anything else on that? Did you feel that on the items it enabled you to have the right level of discussion? Was it helpful? Was it learning? Was it, you know, interesting? Did it feel you understand in relation to your role as governors, or not? Happy with that? Okay. Did everyone feel they were able to have their say and ask their questions and comment? Yeah. Okay. I think the only person I cut off was Jackie. Sorry, Jackie, a little bit. Do people feel that we've had a meeting in line with our culture and behavioural standards today? Everyone happy with that? Great. Anything else anybody wants to say? Okay, fine. Thank you very much. We've literally gone 12 minutes over, but it's been a wide-ranging, I think, list of items on the agenda today with lots of presentations. So thank you for your involvement and patience. And I hope you found it a helpful meeting and something to think about in your deliberations as governors before we meet again. So thank you. And if I don't see you before, some of you have a